Progressive chronic kidney disease is a well-known complication of long-standing type 2 diabetes. Selection of glucose-lowering medications can be difficult as their clearance may be reduced, hence increasing the risk of side effects such as hypoglycemia or lactic acidosis. At the same time, optimal glycemic control is important to minimize long-term complications. Targets for glycemic control in these patients should be individualized, taking into consideration the risk factors for hypoglycemia, the stage of chronic kidney disease, the type of glucose-lowering therapy, and other comorbidities. In patients with an eGFR above 45, metformin can be initiated at a dose of 500 mg daily and up-titrated every 1 to 2 weeks by 500 mg to a maximum total daily dose of 2000 mg. For patients with an eGFR between 30 and 44, metformin should be reduced and the maximum recommended total daily dose is 1000 mg. If the eGFR is less than 30, metformin should be withdrawn or not initiated. SGLT2 inhibitors have been shown to slow progression of chronic kidney disease and reduce cardiovascular disease independent of glycemic control. Hence, most patients with diabetes and chronic kidney disease who have an eGFR above 30 would benefit from addition of an SGLT2 inhibitor. These agents should not be initiated if eGFR is less than 30. However, if the patient is already on an SGLT2 inhibitor, it is reasonable to continue, provided it is well tolerated and the patient is not undergoing renal replacement therapy. GLP-1 agonists are also a good choice and have been shown in studies to have favorable renal benefits by reducing macroalbuminuria, slowing decline in eGFR and progression to renal failure, and they have been found to reduce atherosclerotic cardiovascular events. Dulaglutide has been safely validated for use down to an eGFR of 15. Other GLP-1 agonists such as semaglutide have limited safety data for use in patients with an eGFR below 30. Among DPP-4 inhibitors, linagliptin does not require any dose adjustment and can be used even in patients with end-stage renal failure who require renal replacement therapy. Sitagliptin needs to be reduced with declining eGFR. The maximum daily dose with an eGFR between 30 and 44 is 50 mg and 25 mg with an eGFR less than 30. Insulin is safe to use even in end-stage renal failure, although patients with severe chronic kidney disease are at an increased risk of hypoglycemia, and this should be taken into consideration during prescription of insulin. There are other factors that may increase the risk of hypoglycemia in patients with chronic kidney disease, such as reduced oral intake due to uremia, glucose loss during hemodialysis, and reduced insulin clearance. On the other hand, patients on peritoneal dialysis may experience hyperglycemia due to the glucose load in dialysate and may require up-titration of insulin doses. Sulfonylureas increase the risk of hypoglycemia in patients with chronic kidney disease due to reduced clearance. Dose reduction needs to be considered in mild to moderate kidney disease with an eGFR more than 30, and these agents may need to be discontinued with an eGFR below 30. In summary, glycemic targets should be individualized in patients with chronic kidney disease with the aim of minimizing hypoglycemia. Metformin, DPP-4 inhibitors except linagliptin, and gliclazide need dose reduction with a decline in eGFR. Patients with an eGFR above 30 would benefit from SGLT2 inhibitors due to cardiovascular benefits and delayed progression of chronic kidney disease. GLP-1 agonist dulaglutide can be used with an eGFR above 15 and is associated with lower risk of hypoglycemia.